चेक कर लो। आउट हो गया।
हो तो गया।
हाँ वैसे तो हो गया।
नहीं दिख रहा है कि हो गया। हो तो गया।
वैसे तो हो गया।
नहीं दिख रहा है कि हो गया। इसका ऑडियो तो मुझे ऑन करना पड़ेगा ना?
नहीं सब कुछ
है।
ऑडियो वीडियो तो इनबिल्ट है ना इसमें कैमरे।
अच्छा। तो 10 होने को आए। मैं स्टार्ट कर लेती हूँ। Good afternoon everyone. So the topic of today's class is drugs used in rheumatoid arthritis. So over the next few minutes we'll be discussing the major hallmarks of pathophysiology in rheumatoid arthritis, and then we'll discuss the drugs which help us in say ameliorating the signs and symptoms or the disease per se. So when someone tells this term, when someone utters this term rheumatoid arthritis, what comes into your mind? So the first thing which comes to your mind is this is a disease, arthritis, which involves joints. Okay. So now which joints are involved? Metacarpophalangeal joint, proximal interphalangeal joint. Well, these are the most common joints which are involved, or you can say that starts from these joints. The second thing is this symmetrical? Means suppose someone tells you that joints are involved but then in only one side, say your left side or right side. No, there are less chances that it would be rheumatoid arthritis, but if you see a symmetrical involvement, there are more chances that the disease or the differential diagnosis is rheumatoid arthritis. Now, how do you characterize? So if you palpate those joints, you feel that joint is soft, warm and tender. That is, when you palpate or when you press those joints, the patient experiences pain. Now what happens is there is a type of stiffness present in joints in rheumatoid arthritis which may be greater than 1 hour. Means suppose the patient is lying down or is sleeping and he or she wakes up in early morning, and then say for a duration of 1 hour or more they are debilitated, there is stiffness and they are unable to get up from bed, or they are unable to stretch or do any activity because there is a morning stiffness present in patients of rheumatoid arthritis. Then we come to laboratory findings. So we have means confirmatory things that if this is present, rheumatoid arthritis is there. So rheumatoid factor, anti-citrulline cyclic protein antibody, so anti-CCP antibody, and ESR and C-reactive protein. So rheumatoid factor and anti-CCP antibody are positive, and ESR and C-reactive protein, these two things are increased in patients. So here we see joints involved are metacarpophalangeal joint, proximal interphalangeal joint. Joint involvement is symmetrical. Then we see that those joints are soft, warm and tender. Morning stiffness is present, or stiffness after rest, that is for greater than 1 hour. And then we have rheumatoid factor, anti-CCP antibody positive, and ESR and C-reactive protein is elevated. So these are salient features of rheumatoid arthritis. Now we'll move to pathophysiology of rheumatoid arthritis. So you might be reading this simultaneously in, say, pathology classes also. Now you see we have bone and synovial, this joint. We have cartilage, and here we have synovial fluid. Okay. So what happens is, and this you see is synovial membrane. Okay, and here we have synovial fluid. Now what is rheumatoid arthritis? It is chronic progressive disease causing inflammation in joints, resulting in painful deformity, especially in the fingers, wrists, feet and ankles. Though it is we talk only about joints, but then what happens is this is a systemic disease. So many times you see involvement of gastrointestinal tract, or say pericardium, so pericarditis and things like that also are associated with rheumatoid arthritis. Then just to show you a histo picture of our this joint. So you see these joint covering. So we have type 1 synoviocytes, type 2 synoviocytes. So these two basically are helpful in formation of synovial fluid. So what happens is, with help of these two we can keep our joints lubricated. Now we have sentinel cells. So these sentinel cells are basically first line of defense for our synovial cavity. Then we have this vessels. We have these vessels, and then you see there is a fibrous layer here. So this is normal. In normal circumstances, if you see histology of a cross section of your say synovial cavity, you see synovium, you see fibrous layer. So you see type 1 synoviocytes, type 2 synoviocytes, and then you see sentinel cells. Now in pre-articular phases, what happens is, citrulline is not a normal protein which is present. Basically it is formed by post-translational modification of arginine, and the enzyme which helps is peptidyl arginine deaminase. Now this is formed, and then there are cyclic citrullinated peptides which are formed. So this is present in normal conditions. So arginine through post-translational modification forms citrulline with the help of peptidyl arginine deaminase, and then forms cyclic citrullinated peptides. Then now one of the factors for rheumatoid arthritis has been genetic, and basically associated with major histocompatibility complex class 2 molecules. So HLA, DP, DQ and DR, out of these three, HLA DR4, that is 4th allele, is responsible for or has been found to be associated for rheumatoid arthritis. Now what happens is, because now due to some allelic transformations or mutations, this means HLA-DR helps in, or say translates into anti-CCP, translates means helps in formation of anti-CCP antibodies, that is cyclic citrulinated peptide antibodies. Okay, so antibodies are formed against this protein which is formed by amino acid citrulline, and when this is formed against this, there is destruction of joint and cartilages. Then a second theory says that when there is some noxious insult, be it microbial or mechanical, then what is, I already told you that first line of defenses are sentinel cells. So now these sentinel cells, and then what happens is, if sentinel cells first sentinel cells combat those, and then we have our macrophages, mast cells, dendritic cells, monocytes. So now what happens is, mast cells produce histamine, and dendritic cells and monocytes, they help in production of TNF alpha and interleukin 1. So these things together try to combat this noxious insult. Now with all these, a milieu of all these three, histamine, TNF alpha, interleukin 1 produces some inflammatory response. So there is vasodilation, then there is endothelial activation, so there is increased permeability, and with type 1 activation of there is histamine, in type 2 there is TNF alpha and IL-1. So what happens is, permeability increases. As I already told you, endothelial activation is there and permeability increases. So what happens is, most of them is B cells, T cells, all these, the neutrophils or other cells, they all start migrating, or they all start accumulating in the blood vessels. And you already see here that permeability increases, and then there is accumulation of say monocytes, neutrophils, lymphocytes, etc. in the vessels or in the synovial cavity. Now when you see this layer where there are vessels, so what happens is, citrullinated peptides come and you have anti-CCP antibodies there, they bind to each other, then there is an insult to sentinel cells. These are antigen presenting cells, and what happens is, these present this citrullinated peptide to CD4 cells. Now there is differentiation of these cells, and then forms T helper cells, T helper 1 and T helper 2 cells. Now these T helper 1 and 2 cells, now T helper 1 cells become scars, and here interferon, which produces interferon gamma, and here Th17 cells, they produce TNF alpha and IL-1, interleukin 1 and IL-17. Now what happens is, these together stimulate cells in the synovium, and there is formation of monocyte colony stimulating factor and rank L ligand. Now this rank L ligand and monocyte colony stimulating factor, these both help in differentiation of osteoblasts to osteoclasts. So now we have formation of osteoclasts, and so there is increased joint destruction. Now I already told you that there is destruction of joints and cartilage. I already have showed you the mechanism. Now we see here we have a normal joint, and next we have this joint of a patient with rheumatoid arthritis. So what happens is, there is deposition of granulation tissue, and there is formation of pannus. Pannus is nothing but it is thickened synovial membranes, and they actually grow and infiltrate in the joint spaces in the cartilages, and what happens is these are tumor-like growths. So what happens is they slowly cause joint erosions, and then what happens is the patient develops disability, pain, and all the symptoms of rheumatoid arthritis. Now what are pathological hallmarks? To summarize the pathological hallmarks, basically we saw that we have inflammatory reaction, there is increased cellularity of synovial tissue, and we have joint damage. So what should be the goal of therapy? So the first thing would be the patient is in pain, so we should ameliorate pain. So our first goal is to ameliorate pain, swelling and joint stiffness. Then we come to the next step where we see there are bony erosions and there are articular damages, cartilage damages, so we should prevent those. And then if we are able to do all these things, we are able to prevent articular cartilage and bony erosions. What will happen is we can preserve joint function and further deformity which is caused in rheumatoid arthritis. So we have these three goals as the therapy of rheumatoid arthritis. Now we'll see the drugs which form treatment regimen. So treatment of rheumatoid arthritis, our first goal was to ameliorate pain. So that is done with the help of analgesics. Now we have NSAIDs for that. You already have read NSAIDs in last two classes. Then we have corticosteroids, and then we have disease modifying anti-rheumatic drugs. So nowadays we are focusing on disease modifying anti-rheumatic drugs, that is DMARDs, and these NSAIDs are of course used for when the patient is in pain. Now how do we classify these DMARDs? So we have two types of disease modifying anti-rheumatic drugs. One is synthetic and the second is biologic. So these drugs have been used for say last 2 or 3 decades, and then these are conventional synthetic drugs. The second part is biologics, and the third is targeted synthetic therapy. So these the newer class targeted synthetic therapies, these are basically designed to prevent specific pathway, that is JAK-STAT pathway, and they act on those only. Biologic DMARDs, these are basically drugs which are monoclonal antibodies mostly. So in that class we have TNF-alpha blocking agents, interleukin 6 receptor antibody, interleukin 1 inhibiting agent, and T cell modulating drug. So when we were discussing pathophysiology, we already saw the actions of TNF-alpha and interleukins in the say genesis or in the pathology or causation of this disease. So now when we see the same things and we see which whatever path these drugs are basically blocking to help the patients. So the most common drug which you will study in rheumatoid arthritis would be methotrexate. So first we see the mechanism of action of this drug. So here you see methotrexate, what it does is it basically blocks two enzymes. First is AICAR transformylase, that is aminoimidazole carboxamide ribonucleotide transformylase, and the second is thymidylate synthetase. So as you can see in this diagram, this is inhibited, and so there is accumulation of aminoimidazole carboxamide ribonucleotide, that is AICAR. Now accumulation of this, so when this is increased intracellularly, what happens is adenosine deaminase is inhibited, and when it is inhibited, level of adenosine increases. When this increases intracellularly, what happens is this adenosine will cause, this has anti-inflammatory effect, and so methotrexate, its major mechanism of action in rheumatoid arthritis is anti-inflammatory through inhibition of AICAR transformylase. It has some smaller actions as well. It inhibits DHFR reductase, etc. But then those are very very minuscule in comparison to this. So here, when adenosine increases, what happens is adenosine receptor is stimulated and adenosine signaling pathways cause decrease in inflammation. So it is given in doses of 10 to 12.5 milligram weekly oral, and it has rapid onset of action. Adverse reactions are nausea and vomiting. So what happens is, if it is given orally and we see that there is excessive nausea and vomiting in the patients, we may shift the route to subcutaneous one. Then there are chances of hepatotoxicity, and methotrexate fog is also caused by this drug. So in this, patient experiences forgetfulness, confusion, slow thinking, distractibility, depersonalization, inability to remember words when speaking or writing. So there is basically a state of confusion for the patient. So these three are important adverse effects which patients can observe. Now for methotrexate toxicity, or say for combating this toxicity, we give folic acid 1 milligram per day in the patient. The next drug which we shall discuss is hydroxychloroquine. It does not have such an efficacy as methotrexate, but it also has low toxicity than methotrexate. And in this case, what happens is, if you give hydroxychloroquine, bone erosions are not prevented. Okay, and it is also used in mild or early cases. Mechanism of action is not very clear, but it decreases release of interleukin 1 from monocytes, and if used for a long time, hydroxychloroquine tends to accumulate in melanin containing cells, so there are chances of retinal damage. Also, there can be graying of hair, myopathy and neuropathy. Doses are 400 milligram per day for 6 weeks, and then given 200 milligram per day indefinitely for patients of rheumatoid arthritis. This drug, you might have read about this drug recently. You would have seen in newspapers and everywhere. This drug was a star for quite some days in this COVID times. So this is also used in rheumatoid arthritis, or say was used very frequently in rheumatoid arthritis, but these days when we have some biologic DMARDs, the use of this drug has decreased. Then we have this leflunomide. So when we see pathway of uridine monophosphate production, what we see is we have dihydroorotate, and that is reduced to orotate by dihydroorotate dehydrogenase, and this orotate then forms into uridine 5 monophosphate. Now leflunomide blocks this enzyme or inhibits this enzyme dihydroorotate dehydrogenase, and what it does by blocking this enzyme is ultimately inhibits proliferation of T cells. So we saw that when proliferation of T cells is inhibited, what will happen? The inflammatory response is taken care of, and then we can help the patient. So dose 100 milligram daily for 3 days, and then followed by 10 to 20 milligram once daily. And it also has adverse effects of nausea, vomiting, headache and diarrhea, and it also has some propensity to cause liver injuries, that is, it has elevated liver transaminases. Then in this class, where we are discussing conventional synthetic DMARDs, we have some other drugs which are not used nowadays with frequently they are not used, but then were used earlier and then can be used in patients who are intolerant to methotrexate or have failed on methotrexate. So amongst these drugs are cyclosporine, azathioprine, mycophenolate mofetil, gold compounds and sulfasalazine. So cyclosporine, what it does is it inhibits production of interleukin 1, interleukin 2 receptor, and it also, as interleukin 1 and 2 receptor production is inhibited, what happens is macrophage and T cell interactions are also inhibited. Whereas in azathioprine, what happens is it inhibits B cell and T cell functions. And one other drug, sulfasalazine, this actually you will read more frequently in or use more frequently in inflammatory bowel disease. So sulfasalazine is composed of sulfapyridine plus 5-amino salicylic acid. Now when you read in inflammatory bowel disease, you will learn that 5-amino salicylic acid that is not absorbed in the intestines, and because it is not absorbed, through its local action it helps in that disease, in inflammatory bowel diseases. But in case of rheumatoid arthritis, we have a second component of sulfapyridine. So sulfapyridine is absorbed, and then what happens, it blocks, or say it decreases proliferation of B cells and T cells. Now we saw this diagram earlier when we were discussing pathophysiology. So here we saw if there is a noxious insult, what happens is first sentinel cells come to rescue, then we have mast cells, dendritic cells and monocytes. And here what happens is there is production of TNF alpha and interleukin 1, which try to help in having an inflammatory response, an immunological response against that insult. Okay, and in that case what happens is there is increased proliferation of T cells, B cells, and there is increased permeability of endothelial cells, and we have increased number of cells in the synovial cavity. Now anti-TNF-alpha biologics, what they do is they block this TNF-alpha, these bind to TNF-alpha, and what happens is they take care of that proliferation of B cells and T cells part, and so the inflammatory response is reduced. And then what happens, they have multiple mechanisms of action. So one, it is done, and the second thing which is done is, when we saw this part where there was production of Rankel ligand and there was formation of osteoclasts, or there was differentiation of osteoblast into osteoclasts, what happened is this stimulates the stimulation of production of TNF alpha and interleukin 1, that is also blocked because you are giving TNF alpha antibodies or anti-TNF alpha biologics. So these two steps are blocked and we have inflammation is reduced. So we will be seeing these three drugs, that is etanercept, infliximab and adalimumab. Now adalimumab and golimumab, they both are similar in morphology and similar in action also. So when you first of all we come to etanercept. Now etanercept is a fusion protein which has P75 TNF receptor moiety, and to this fusion protein, when TNF alpha is attached to that, what happens, it binds to that and inhibits both TNF alpha and TNF beta. So what will happen is that the proliferation of inflammatory cells will be reduced, of course, and this can be given 20 milligram subcutaneous twice weekly, and this drug is well tolerated. Basically all TNF alpha, anti-TNF alpha biologics are well tolerated drugs, and that is why we are not using other synthetic or conventional synthetic DMARDs nowadays if the patient is not improving on only methotrexate, we tend to add some anti-TNF-alpha biologic to the therapy. Now infliximab, that is a chimeric antibody. Chimeric means it has combination of two lineages of antibodies, and 25% is derived from mouse and 75% from humans. So you can see this FC portion is derived from humans here, and this is more immunogenic than etanercept, and it also has a similar action that it binds to TNF alpha, and then it will prevent formation of other inflammatory cells or other inflammatory cytokines, to be specific. Then we have adalimumab and golimumab. They are 100% human biologics, so that is why they will be less immunogenic than infliximab, which is chimeric. Then we have non-TNF alpha biologics as well. So in non-TNF alpha biologics we have IL-1 antagonist first, that is anakinra, which acts on IL-1 receptor, and it is less effective than TNF inhibitors. That is why, as it is less effective, but it is used in resistant cases, the cases which are not taken care of by methotrexate and TNF alpha biologics. Then we have rituximab, which is an antibody against CD20 on B cell surface, and it causes destruction of B cells. It is also a chimeric monoclonal antibody. Then we have abatacept, that is T cell co-stimulatory signal inhibitor. So I think you would have read in microbiology that for activation of T cell we need two stimulus. Only one stimulus is not enough. So the first stimulus being this activation MHC and T cell receptor. Now the second stimulus which activates T cell most frequently is CD80 or 86 on antigen presenting cell, which goes and bind to CD28 on the T cells. Now if these two stimulus are met, then what happens is there is proliferation of T cells and production of cytokines. But abatacept, this comes and bind to these CD80, 86 site, and then this co-stimulation is inhibited. So when this is inhibited, what will happen? We don't have proliferation of T cells and cytokines also. Now because there is this lack of proliferation of T cells, if you are giving abatacept, you have reduced the proliferation of T cells. So what will happen? We have increased risk of infections. So in all these cases where we are trying to take care of the inflammatory response of our body, we are increasing chances of infections. What other drug is? Tofacitinib. Now what happens is cytokine binds to its cell surface receptor, and then it leads to receptor polymerization. So after receptor polymerization, what happens is tofacitinib inhibits phosphorylation and inhibits activation of this JAK. Now this Janus kinase, this cannot phosphorylate the cytokine receptor, and therefore STAT protein, it does not get attached. And so when STAT does not get attached, they are not phosphorylated, and further gene transcription and cytokine production, that is inhibited. So here again we see that cytokine production is inhibited. So adverse drug reaction, when we talk of ADRs, we have increased risk of infection. Tofacitinib is also indicated in cases of moderate to severe active rheumatoid arthritis in adults who fail or are intolerant to methotrexate monotherapy. Dose is 5 mg twice daily, and ADR we already discussed, that is increased risk of infections. Then we have this drug tocilizumab, which is anti-IL-6 biologic. So This also again action is same, that it will inhibit further production of cytokines and proliferation of B and T cells, and as it inhibits normal inflammatory responses of our body, we have ADRs as serious infection, including tuberculosis, fungal infections, viral infections, and other opportunistic infections. So in rheumatoid arthritis, in mild disease, in low or low risk patients, we start with DMARD monotherapy. So we can start with, say, conventional synthetic DMARD. In those we can choose between methotrexate, hydroxychloroquine or leflunomide. So in hydroxychloroquine is given only in very early stages of disease. Mostly we give methotrexate. Then we reassess the patient, and if the patient, if that therapy is not sufficient or the disease is progressing, we shift to double therapy. So these double therapy may essentially be of conventional synthetic drugs only. If we cannot contain the disease at that stage, we add or we switch to anti-TNF-alpha biologics. And if we see some serious adverse reactions to those drugs, we can switch to non-TNF-alpha biologics. So if the cases are resistant to all these therapy, we can switch to non-TNF-alpha biologics. In cases of moderate to severe disease, we can start with methotrexate monotherapy, but most of the times double or triple therapy is recommended. And then if on reassessment we cannot see any improvement, we then add or switch to other DMARDs, or we add abatacept or rituximab to the existing therapy. And when there are serious ADRs to any of these, we switch from one class to other, because most of the adverse events of the classes are also similar amongst them. So we have guidelines by American College of Rheumatology of 2015, though they are in process of amending it and will have some guidelines in 2020. So these also, that low disease activity without poor prognosis, DMARD monotherapy, and if there is low disease activity with poor prognosis, we start with methotrexate monotherapy or combination DMARD therapy. Then we have reassessment, and we add something from the conventional therapies, or we can switch to the biologic therapy depending on the status of the patient. So we have some non-pharmacological treatment approaches like hot or cold massage, physiotherapy, rest and splinting, and amongst the say pharmacotherapy, we already discussed that our main target is to ameliorate pain, to prevent joint erosion and to prevent disability. So we follow treat to target approach, where we see remission and low disease activity is maintained, and for this we can use disease modifying anti-rheumatic drugs. The drugs we have discussed were methotrexate, hydroxychloroquine, leflunomide. Then we have some drugs which are not used so frequently now: cyclophosphamide, azathioprine, sulfasalazine, gold compounds. Then we come to biologics, where we have anti-TNF-alpha biologics, IL-1 receptor antibody, and we have IL-6 receptor antibody, and then we have JAK-STAT pathway targeted therapy, that was tofacitinib. Thank you. So for the management part of this rheumatoid arthritis, a faculty from rheumatology will join us. around in 10 to 15 minutes.
बस आपको ही फोन करेंगे कि हाँ
हो गया आपका?
थ्योरी कवर कर लिया आपने।
अच्छा,
योर प्रेजेंटेशन
बड़ा बोरिंग नहीं होता?
कितने बच्चे हैं, क्या है,
किसको समझ में आ रहा है, किसको नहीं आ रहा है?
कुछ ना बता। और अभी बात ये नहीं बता रहा कितने सुन रहे हैं, मतलब लॉकडाउन कितने हैं, उसमें से सुन रहे हैं तो और भी कम होंगे।
हाँ, कम से कम बैठे तो कुछ रिस्पॉन्स आता है, फिर पूछता है, फिर वो होता है।
पता चलता है कि हाँ हिंदी बोल रहा है, हाँ जल्दी होता है।
किसको नींद आ रही है तो सच जाओ। कौन है? Good afternoon to everyone. Today's topic is management of rheumatoid arthritis. Myself Dr. Danvir from Rheumatology Department. As you know, this is the commonest arthritis, that is inflammatory arthritis you can say, worldwide, and the prevalence of rheumatoid arthritis is 1%. That means out of 100, 1 person will have rheumatoid arthritis. Either somewhere in your relatives also may have this kind of arthritis. If you see in India and China, the prevalence is slightly lower by around 0.4%, but overall the prevalence is 1%. I would like to cover this topic under the heading of correct diagnosis and organ involvement, disease assessment, treat to target, which drug and how to monitor drug side effects, how long to continue treatment, can we stop treatment. These are the questions which is frequently asked by the patients, and treatment in some special situations. You know, rheumatoid arthritis has some stages. It has preclinical RA, early RA, then established RA and burnt out RA. Preclinical RA is defined as the period of autoimmunity. Autoimmunity means antibody positivity in the form of rheumatoid factor or anti-CCP, that is preceding the initial articular signs and symptoms of disease, that has been termed as preclinical RA. So once the patient starts joint pain, that is arthralgia, at that point preclinical RA stage goes out and clinical RA starts. So if there is no frank arthritis and patient only has morning stiffness and some arthralgia with the positivity of RF and anti-CCP, that is considered as a early RA. And once the patient develops frank arthritis and fulfills the criteria which I will discuss in subsequent slide, then it is known as a rheumatoid arthritis, that is established rheumatoid arthritis. Over the period of years, when the synovium goes out and every kind of damage happens and there is no inflammation in the joints, that is considered as a burnt out rheumatoid arthritis. In 1987, American College of Rheumatology, that is also known as ACR 1987 criteria, given the classification criteria to make the diagnosis of rheumatoid arthritis. So out of these 7 criteria, we should have 4 clinical criteria to fulfill the rheumatoid arthritis diagnosis. So these 7 criteria are morning stiffness, arthritis of 3 or more joint areas. Joint areas you can pinpoint here that joint areas are considered in this classification criteria. That means MCP joint area, PIP joint area, wrist joint area, so either side of the joint area. Arthritis of hand joints, symmetric arthritis, that means bilateral symmetrical arthritis will be there. Rheumatoid nodule usually present over the pressure sites. Serum rheumatoid factor, radiographic changes in X-ray, that is usually in the hand X-rays. So if 4 criteria are fulfilled, then rheumatoid arthritis diagnosis can be made. To make the diagnosis in early RA, there was some modification in 2010 by joint classification criteria ACR and EULAR. ACR is American College of Rheumatology, EULAR is European League of Rheumatism. So both of them given a joint classification criteria in 2010. So in this we have the scoring system. We have 4 domain, and out of these 4 domain, one is joint involvement, that is arthritis. We have a scoring system as you are able to see here, 0, 1, 2, 3, 4, 5 according to the joint involvement. Serology, that is already discussed, rheumatoid factor and RF positivity. So titer, if these are more than 2 times, these are considered high titer, gives a score of 3. If less than 2 times, it is considered as a low titer and score gives as 2. Acute phase reactant, ESR CRP, duration of the symptoms less than 6 weeks or more than 6 weeks. So if you score more than 6, then there is a definite RA, and if you score less than 6, then it does not classify the criteria of rheumatoid arthritis. But at the same time, these patients should not be explained with any other disease better than RA. So this is the clause. You know, apart from the joint involvement, this is a systemic disease which can involve any kind of system in the body, commonest extra-articular system involvement is keratoconjunctivitis sicca, where we have xerosis of eyes and mouth. Xerostomia and periodontitis is also seen. Pulmonary involvement in the form of pulmonary effusion, pulmonary nodules. These nodules are similar to rheumatoid nodules at the periphery. Interstitial lung disease, pulmonary vasculitis, organizing pneumonia. Cardiac involvement can be pericarditis, ischemic heart disease IHD, myocarditis, cardiomyopathy, arrhythmia, mitral regurgitation. Renal involvement, membranous nephropathy, secondary amyloidosis in long-standing rheumatoid arthritis. Endocrine involvement, hypohidrogenism. And skin involvement, rheumatoid nodule, purpura, pyoderma gangrenosum. Pyoderma gangrenosum is kind of skin lesion which has ulceration and it is difficult to treat. Osteoporosis, where the T score goes less than 2.5 as compared to the AIIMS population. Vasculitis can be anywhere, GI vasculitis or peripheral vasculitis. Hematological anemia of chronic disease is the most common manifestation of hematological manifestation. Neutropenia, splenomegaly, these are seen in Felty syndrome. Large granular lymphocyte leukemia and lymphoma can be seen in RA patients. Cervical myelopathy, that is because of atlantoaxial involvement and dislocation of the joint. So when you have diagnosed the patient, now patient wants to know whether I will have good prognosis or bad prognosis. So based on this poor prognostic factor, you can counsel her or him. Just presence of the rheumatoid factor and titer gives the bad prognostic factor. Presence of antibodies, these are anti-CCP antibodies, also gives poor prognostic factor. Presence of shared epitope, HLA-DR alleles and number of copies. So this is also one of the poor prognostic factor in rheumatoid arthritis. Presence of erosive disease at presentation, that means it is very aggressive disease. When there is erosive changes in the initial presentation itself, that means it is very aggressive disease and you have to be aggressive in treating also. Disease activity at present, that I will discuss how to calculate the disease activity. Magnitude of ESR and CRP, presence of nodules or extra-articular manifestation, that means disease is beyond the joints and extra-articular manifestation happens usually in the long-standing RA, but if these are present, that means that is poor prognostic factor. Female gender, current and past smoking history is also one of the poor prognostic factor, and obesity. So whatever the disease is present in the patient, we have to objectivize that how to calculate the disease in the numerical form, that is known as a disease activity score. So once you know the score, you can consider that this is severe, this is moderate, this is mild disease, and then you can treat the patient accordingly. Based on this activity score, you also treat the patient for the target. So what is your target, that is also can be decided objectively by using these activity score. So this is one of the activity score which objectivize the subjective findings. That means if someone says that I am having very much pain but swelling and synovitis is not there, that is not because of arthritis, it is because of something else. So it can be subjective, can be something else, but objective findings should be there. So these are the parameters which calculate the disease activity and gives you some numerical value, so you can calculate and you can decide what is your goal. As we discussed, RA starts somewhere, then goes in the various phases: early RA, rheumatoid arthritis, established RA, and then burnt out RA. So as you know that if fire starts initially, if you can control initially itself, then damage is prevented. So early RA and established RA has maximum inflammation, where you can have some disease modifying active disease drugs that can be given at this point of time, otherwise it will lead to burnt out RA, and that is totally damaged. There is no intervention will help in this at this point of time. So you have to act at the active disease state, that is early RA and some of the established RA. We do not want to have damage or burnt out RA where we cannot do anything. So based on the amount of fire or inflammation or disease activity, we have to decide our armamentarium, that is based our drugs which have in our kitty. We have various kind of drugs which I will discuss later on. So based on the amount of inflammation we decide, disease activity we decide the treatment protocol. So management of rheumatoid arthritis is considered in various forms: symptomatic drug treatment, disease modifying. Disease modifying means you are modifying the natural course of the disease. So once the diagnosis has been made, you do not want to have damage of the patients in joints and various other organs. So you are modifying the disease, and that is called disease modifying drugs. Complementary and alternative medicines are also there. Psychosocial intervention. As soon as the patient knows that I am suffering from rheumatoid arthritis and it is going to be a long term disease, so patient goes in the state of depression and anxiety. So psychosocial intervention is also essential. Rehabilitation and exercise. If the patient has developed some deformities, then patient has to be rehabilitated, and we should advise her regarding the particular exercise to restore this activity. Then at last, when there is totally damage, we have to do some surgical intervention to have maximize our daily activity. As we have discussed, early rheumatoid arthritis versus burnt out RA. In this picture you can see there is maximum inflammation, and this is early RA when there is starting of the rheumatoid arthritis. Over the period of 5 to 10 years, patient develops some deformities. These are typical rheumatoid arthritis deformities. You can say botaniera deformity, ulnar subluxation of the MCP joints, wrist joint damage, botaniera deformity, and these various kind of deformities are seen over here. These are deformity develops over the period of 5 to 10 years in established RA. So what do you want to do in these patients? Once the diagnosis has been made, you have confirmed the diagnosis, you have established the disease activity, you have objectivized your disease activity in the form of scoring. Now you do something, so that can be the symptom control. So that was the only thing which was available previously before 1970. Then some of the disease modifying drugs came in the form of methotrexate, sulfasalazine. So these drugs modified the natural course of the rheumatoid arthritis. Subsequently, we had treat to target achievement also. So we have targeted some disease activity, that this is our target to achieve in these patients. Then drug-free remission or cure. See, in our childhood we used to wish that we should have bicycle, and subsequently we wish that we should have motorcycle, then car, and then bigger car, and these kind of things. These are our achievable targets and we act accordingly. So these are the wishes we do have. If we have motorcycle, we do think that we should have car. So if the patient is having achieved the target, then we think about the drug-free remission and cure. So this is the future of rheumatoid arthritis, where we can think of drug-free remission and cure of the rheumatoid arthritis. Right now we have some of the drugs in our armamentarium, that is NSAID as a painkiller, steroid can be oral or injectable, DMARDs, disease modifying anti-rheumatic drugs, that is monotherapy or combination therapy, biologics, anti-TNF or non-anti-TNF agents are available. If you know this person is Yella Paragada Subbarao from Chennai, and he has discovered METHOTREXATE, and that is the anchor drug for treatment of rheumatoid arthritis. He has also discovered folic acid, diethylcarbamazepine, so he is a pioneer in discovering these drugs, and we do not have any other drug other than diethylcarbamazepine for the treatment of filariasis yet. Among the disease modifying drugs, the listed drugs are available in the market for the treatment of rheumatoid arthritis. These are the hydroxychloroquin, which stabilizes the lysosome and acts as an anti-rheumatic drug. Sulfasalazine, immunomodulation of unclear mechanism, but some of the mechanisms shows that there is increased adenosine level intracellularly, which is as an anti-inflammatory mechanism. Methotrexate, that inhibits inhibition of aminoimidazole carboxamide adenosine ribonucleotide AICAR transaminase, that increases the intracellular adenosine, and you know that adenosine is anti-inflammatory. Leflunomide, inhibition of dihydroorotate dehydrogenase needed for the deneosynthesis of pyrimidine, and leflunomide inhibits this dihydroorotate dehydrogenase and acts as an anti-inflammatory drug. Biologics DMARDs, as we have discussed, TNF and anti-TNF, anti-TNF and non-anti-TNF. Anti-TNF drugs are adalimumab, infliximab, certolizumab, golimumab and etanercept. Nomenclature of these antibodies, you must be aware of that. XI, somewhere XI means chimeric, mu, that is fully human, and Ju, it is humanized. Some of the portion is from the animal origin, otherwise most of the portion is humanized. So Ju, XI, mu, these are the nomenclature where we can have the humanized, chimeric or fully human antibodies. Etanercept is receptor antagonist, abatacept is also a receptor antagonist, so these also act accordingly. Abatacept is selective co-stimulatory molecule fused to immunoglobulin to inhibit T cell activation, so it inhibits the T cell activation. Tocilizumab, IL-6 antibody, rituximab, anti-CD20 antibodies, tofacitinib, that is genus kinase inhibitor. This is new drug in the market. So you must know the properties of the drugs. As we have discussed that NSAID is to relieve the pain and swelling, there is no DMARD effect of the non-steroidal anti-inflammatory drugs. It has advantage of having quick action, it is short acting, but lot of side effect, renal side effect, gastric ulceration, fluid overload, all these adverse effects are there, and there is no DMARD effect of the NSAID. So for the symptomatic purpose we can give NSAID, but otherwise there is no other role of NSAID in rheumatoid arthritis treatment. Steroids, we do use steroids as an initial bridge therapy because it relieves pain and swelling. It has quick action. It is short acting and also has DMARD effect. So those patients who are getting the Ayurvedic treatment, they are getting these steroids and they do have some DMARD effect. Adverse effect, when given in higher dosage, it has lot of adverse effect. As you know, diabetes, osteoporosis, so many side effects are there. DMARDs that we have discussed, methotrexate, sulfasalazine, leflunomide, these are the drugs which give some DMARD disease modifying effect. These are cheaper. These are short and long acting, have the disadvantage or advantage also can be considered it. Effect takes some time, so patient think that this drug is not acting and he or she can switch to some other treatment thinking that this drug is not at all effective to me. So you should explain to them that it may take some time. Can be foreseen that adverse effect, these are there in the form of myelosuppression or some hemoglobin or leukopenia, anemia, all these are side effects can be seen, but that can be foreseen by doing regular testing. Biologics, these relieves pain and swelling. It also has DMARD effect. These are excellent effect. So this is the one of the most important advantage of these biologics. Cost is one of the disadvantages because they are costly. Nowadays cost of the biologics is also reduced because of the competition among the pharmaceutical companies. Need to give DMARDs along the biologics also sometimes, not always, do occur and may be severe as a side effects also can occur in these patients in the form of reactivation of the tuberculosis. Sometimes the anaphylaxis reaction also can happen because of these are antibodies and these are generated from the some of the animals. Coming to the other properties of DMARDs, these are methotrexate, sulfasalazine, hydroxychloroquin and leflunomide. Efficacy of methotrexate and sulfasalazine is excellent. Leflunomide is also having excellent efficacy. HCQS is a weak DMARD drug, but it is very safe. No need to have monitoring at all. So we are giving it right and left this drug. Hepatic toxicity is usually seen in methotrexate and sulfasalazine. Leflunomide also has. There is no hepatic toxicity of HCQS. So we do monitor with CBC and liver function test, and I will come to that. So it is safe in males. Methotrexate, oligospermia sometimes has been reported with sulfasalazine, but it is also reversible. HCQS is safe. Leflunomide is safe in male patients. In pregnancy, methotrexate and leflunomide is contraindicated. Sulfasalazine is safe. HCQ also is safe. During lactation, methotrexate and leflunomide are contraindicated. You should not use these drugs during pregnancy and lactation. Otherwise, sulfasalazine and HCQ both are safe. Adverse effects, GI intolerance with methotrexate is seen. 1 to 2% patient complain about the nausea, vomiting, and some of the time it is so severe that patient some thinks about the taking methotrexate and he vomits or she vomits. That is methotrexate flu. So you should think about that methotrexate flu when the patient say that even after thinking about the methotrexate taking, and before one day I used to develop nausea and vomiting. It also happens in the case of methotrexate. Some of the patient develops this. So idiosyncratic reaction also happens with sulfasalazine. Maculopathy, that is very rarely, 1 in 1 lakh patient only with the HCQS. So it is really very safe drug in rheumatoid arthritis. It is these drugs also used in SLE. Leflunomide sometimes may cause hypertension. Pill load, you can think that once a week methotrexate is given. That is because of its metabolism and some long-term effect on the GI epithelium. Sulfasalazine 2 to 3 tablets per day. So this is has higher pill load. So if you think that 4 to 6 tablets per day can you take, this is really high pill load. HCQ just 1 tablet per day, lefnomide just 1 tablet per day. So dose as is given in this chart below, you can remember. As I was discussing the adverse effect, myelosuppression, liver enzyme elevation, some of the renal dysfunction, these can be monitored by doing CBC, LFT, RFT frequently. So these most of the time we are doing it at every 3 months, but here we have given some of the time interval where we should do. So now coming to the combination versus monotherapy. So who should be treated with combination therapy, who should be treated with monotherapy, and we were discussing these poor prognostic factors, disease activity parameters. So here the role comes of combination versus monotherapy. When you think the disease burden is low at the starting, you can give monotherapy, and if you think the disease activity is high and poor prognostic factor, which we have discussed in the initial slides, if these are present, we should treat with a combination therapy, or you can think of treating patient with anti-TNF when there is already patient has been treated with monotherapy or combination therapy. So the role of disease activity calculation and poor prognostic factor comes when you decide the treatment protocol. So someone can ask what could be the combination. Combination can be METHOTREXATE plus sulfasalazine plus lefnomide also, or METHOTREXATE plus sulfasalazine plus HCQS. So any of these drugs can be combined, provided that you are monitoring side effects frequently. Even though anti-TNF and non-anti-TNF biologics also can be combined with these conventional DMARDs. So any of the drugs can be combined. There is no contraindication of giving combination therapy either of these drugs. Again, you have to monitor, because how do you say then that is responding or not? So once you know the patient is responding, then only you will continue the drugs. Otherwise, patient will go somewhere else. So disease activity, again at that interval of 3 months, you have to calculate with the side effects parameters. So if the patient is having either side effect, then you have to switch the therapy, or if the patient is not having the desired effect in the form of reducing the disease activity, then also you have to switch from given that initial therapy to another therapy, or you have to switch add the initial monotherapy into combination therapy. So depending on the response at the end of 3 months, at the end of 6 months, when you are calculating the disease activity, you are assessing the adverse effects of the drugs. Now, how long to continue treatment? Can we discontinue treatment? It has to be lifelong if you are counseling the patient. Sometimes if there is patient is in remission, that means you are calculating the disease activity, and according to the parameters the disease is in remission, because there is no joint pain, no morning stiffness, and nothing is there. Patient does not require any NSAID requirement. So these are the things where patient can be assessed, and there is the patient is in remission. That means you can think of stopping the treatment if patient is continuously in remission for 2 years, but there is a risk of 50% relapse, so that has to be told to patient. Treatment in special situation. What are those special situations? Rheumatoid arthritis complicated with ILD, rheumatoid arthritis with liver disease, rheumatoid arthritis with renal involvement, patient is having rheumatoid vasculitis, patient is having pregnancy. So these are the special situations where you have to think something and other than routine treatment which is given in RA. If the patient is having interstitial lung disease, then what can you do? That ILD has to be treated because it is progressive. It is treated as CTD associated ILD that can be treated with cyclophosphamide, MMF, rituximab. So dose is standard, which you may not like to remember, but cyclophosphamide is 500 to 750 milligram per meter square, MMF is 2 to 3 gram per day, rituximab is also 350 milligram per meter square. So these are the drugs which can be given in ILD for the treatment purpose. If the patient is having ILD and arthritis, that is arthritis also has to be treated. Methotrexate is controversial in the presence of ILD. Nowadays it is considered that methotrexate can be given. Earlier it was contraindicated. Nowadays many of the physicians give that methotrexate along with other treatment of the ILD. Leflunomide also can be given. It was controversial earlier, but now can be given. Sulfasalazine, HCQS, rituximab, yes. Rituximab, yes, because it acts on both ILD as well as joint factors. Anti-TNF we should not give because we do not have any data of these. In the presence of liver disease, that is chronic hepatitis B and C, if these are detected, what should you do? We cannot give steroid because there is chance of flare of the hepatitis B and C. Methotrexate, that is toxicity, should not be given. Leflunomide should be avoided. Sulfasalazine can be given, HCQS can be given. Rituximab should not be given. Anti-TNF we do not have data. So we have only sulfasalazine and HCQS safe drugs during the chronic hepatitis B and C infection in rheumatoid arthritis. In renal failure, we can give treatment according to creatinine clearance only. If the patient is having pregnancy, then what to do? There is chart given and which contain that which drug is falls under which category of during the pregnancy. So corticosteroids are category C, it is safe, can be given. Sulfasalazine category B, it also can be given during pregnancy. If the patient does not require any treatment during pregnancy, any kind of treatment should be avoided. These drugs should be given only when there is requirement of the to control the disease activity. Otherwise, we should avoid every kind of drug during pregnancy because some of the side effects happens during pregnancy to the fetus. So corticosteroid are category C and safe, can be given for the joint purpose. Sulfasalazine also safe. Azathioprine category D, but still it is safe if the patient is considered to be having some of the involvement of the kidney in the form of lupus nephritis, not in RA but in SLE. Methotrexate and leflunomide category X strictly contraindicated and should not be used in any form. Antimalarial, that is HCQS, can be given. Anti-TNF can be given. Abatacept, also rituximab, all these are drugs which falls under category C, but we do not have long-term and established data to comment on about the rituximab, tocilizumab and abatacept. As I was discussing, long-standing rheumatoid arthritis can have vasculitis, either GI vasculitis or peripheral vasculitis. So that is inflammation of the vessel wall called vasculitis. In the presence of rheumatoid arthritis, if this happen, this is called rheumatoid vasculitis. Otherwise, primary vasculitis in the form of unconstructive vasculitis and polyarthritis nodosa, all these are the vasculitis which are primary vasculitis. Here, in the presence of rheumatoid arthritis, the patient develops vasculitis, that is secondary vasculitis, and it is called rheumatoid vasculitis. These are the presentation of rheumatoid vasculitis in long-standing rheumatoid arthritis patient in the form of gangrenous changes of the toes, fingers, nose, ear pinnas, and sometimes GI involvement also. So how do you treat? This is not as severe as primary vasculitis, so you can give sulfa, that is the cyclophosphamide if this is organ threatening. Otherwise, routine treatment can be given along with the high dose of steroid. So cyclophosphamide, the treatment in severe rheumatoid vasculitis, or in mild cases you can give high doses of steroid and can be controlled. So how do you establish the diagnosis? Just clinical diagnosis. I would like to thank now, because I think there is no interaction between students and teachers.
ईमेल कर सकते हैं.
Yeah. So you can mail me. Should I give mail? So this is DANBAADU2000@gmail.com. You can mail me, and I would like to answer all those questions which you will raise. Thank you so much.
इसमें कितने लोगों ने सुना किया?
इसमें
लाइव चैट में ना अपना नाम लिख के बस check करना है.
कहाँ पे?
चैट में अपने नाम और रोल नंबर लिखे हैं ना इन लोगों ने.
हाँ हाँ.
कंकरेंट व्यूअर्स अभी 2 हो चुके हैं. ये थोड़ी देर पहले 6 थे.
मतलब
जो भी स्क्रीन को देख रहे हैं वो लोग.
ओके, बस.
ये पेमेंट लगा के गए.
वेरी गुड.
ये तो भी आफ्टरनून इन्होंने बोल के खुद कराया था कि मॉर्निंग में मत लो. मॉर्निंग में तो 0 ही होगा.
अच्छा, बहुत अच्छी बात है. मज़ा आ गया.
इसको एंड स्क्रीन कर दीजिए.